For this assignment, I chose to cover panic disorder. And so along with that, I'll be discussing the DSM-5 diagnostic criteria for panic disorder, as well as one selected theory on the etiology of this disorder. And then I'll sort of be talking about some of the treatment implications related to that selected theory of etiology of panic disorder. And so the DSM-5 criteria for diagnosis of panic disorder includes having recurrent and unexpected panic attacks. And so what a panic attack is an abrupt surge of intense fear or discomfort that usually reaches its peak within minutes and then sort of dissipates. And so along with this, in order to receive a diagnosis of panic disorder, someone presenting with this would have to have 4 or more of the following symptoms related to that. So they might experience palpitations, so a pounding heart or an accelerated heart rate. They could experience sweating, trembling or shaking, sensations of shortness of breath or the feeling of being smothered, feelings of choking, chest pain or discomfort, nausea or abdominal distress, the feeling dizzy, unsteady, uneasy, or lightheaded, like you're going to pass out or faint, either feeling heat or chill sensations, so either one of those, numbness or tingling sensations, typically in the extremities, and then derealizations, feelings of unreality, like you're sort of disconnected from reality, or depersonalization, which is sort of being detached from yourself and feeling kind of detached from your physical body. Fear of losing control or going crazy, and then fear of dying. So those are all symptoms of panic disorder, that someone with this disorder would experience during a panic attack. Additionally, in order to be diagnosed with a panic disorder, at least one of these attacks has to be followed by 1 month or more of one or both of the following. So it has to be followed by a month or more of persistent concern or worry about having another panic attack. And then the consequences of that panic attack, so going back to, those feelings of going crazy or being detached from yourself. So that might be associated with panic disorder, or a significant maladaptive behavior change related to those attacks. So changing your behavior in order to, or to feel like you're preventing yourself from experiencing another panic attack. So some avoidant behavior. And then additionally, in order to be diagnosed with panic disorder, these panic attacks cannot be attributable to some other physiological effect or related to any sort of substance use. So the panic attacks can't stem from any sort of drug abuse or medication or medical condition. And then additionally, these panic attacks can't better be explained by some sort of other mental disorder. There are many theories on the etiology of panic disorder, and some of those theories range from biological causes, genetic, so they could be genetic neurochemical causes, or environmental effects, conditioning effects, things like that. So for this assignment, I chose to sort of cover a little bit of both of that by discussing the diathesis stress model of anxiety disorders and panic disorder in particular. So what this model basically says is that there are genetic predispositions that a person may have inherent in them that would be a risk factor or leave them more susceptible to having a diagnosis of panic disorder. But those genetic and biological predispositions in and of themselves don't mean that a person is going to have that diagnosis. And so a person, in order to qualify for panic disorder, would have that genetic predisposition, as well as some sort of environmental or real world stressor that sort of acts as a trigger to triggering those panic attacks or triggering that disorder. And so studies in the text have sort of linked what's known as physiological hyperarousal to panic disorder. And so that sort of explains some of those somatic manifestations that I discussed earlier. The dizziness, shortness of breath, things like that are sort of related to a physiological hyperarousal in the brain that would cause that. And so related to that, the text also discusses genetic predisposition to neuroticism, which is linked to anxiety disorders. And then related to brain biology, fMRI studies and other studies have shown that increased activation in several parts of the brain, primarily the amygdala, also the hippocampus, is associated with, these areas of the brain are associated with fear conditioning. And so people that have anxiety disorders and panic disorder have heightened activation in those areas of the brain related to fear conditioning, which sort of causes some of that, can cause some of that physiological hyperarousal. And so that's sort of related to the diathesis stress model, because it's saying that there is this physical biological component that would leave a person predisposed to a panic attack or a panic disorder, but those specific instances of panic attacks are triggered by environmental causes, so life stressors, things like that, or possible past traumatic events. And then, once those panic attacks occur and a person has experienced those panic attacks, then they may engage in some of that avoidant behavior. So trying to avoid those panic attacks by using, maladaptive behavior changes like the DSM discusses, or a constant fear of having another panic attack because they know what that feels like and they're trying to avoid experiencing that again. And so based on the etiology that I kind of discussed there are certain treatment implications to sort of reduce symptoms and treat panic disorder. And so I believe that a combination of both medication and psychotherapy is probably the best way to handle panic disorder. So related to that biological component, the serotonin system in our brain is related to feelings, can be related to feelings of anxiety. And so medication management can sort of help balance that neurochemical side, specifically medications like SSRIs, which are selective serotonin reuptake inhibitors, that sort of block the reuptake of serotonin in the brain in order to maybe reduce some of those overall feelings of anxiety. And so that's the medication management side, which can sort of help deal with maybe that biological neurochemical component of panic disorder. And then on top of that, psychotherapy will be really important and effective for panic disorder to sort of address some of those real world environmental concerns or causes of the panic disorder. So maybe addressing any sort of past trauma or past experiences, current life or past life stressors, and then also teaching coping skills to sort of reduce that that avoidant behavior or that fear of another panic attack reoccurring. Because if these people diagnosed with this have those coping skills in place, then they will be able to implement them if they feel afraid of another panic attack coming, or they feel another one coming on, so that maybe they can avoid having another panic attack without going into some of that maladaptive behavior. So without, maybe turning to illicit drugs or anything like that to avoid having another panic attack or to calm them down. And so the last question is, why do I believe that some people experience this disorder and others do not? And so I kind of touched on that earlier, and I believe that that diathesis stress model can really sort of explain some of that. So I believe that some people do have that genetic, biological, neurochemical predisposition to hyperarousal or increased activation in the amygdala. And so without that predisposition, people may experience significant life stressors, or maybe past trauma, but never experience panic attacks or get a diagnosis of panic disorder because they're not as susceptible and don't have those risk factors. And then the people that do experience that panic attacks, recurrent panic attacks, and panic disorder have sort of that combination of both the biological and the environmental stressors and predispositions that are leading to those panic attacks. Thank you.